What's up, guys? It's September 16, so I'm back on the wards rotation in internal medicine residency. My residency started with a 3-week wards rotation. It's a 3+3 schedule, and then for the past 9 weeks, I've been on clinic, internal medicine clinic, and 2 subspecialty rotations, cardiology and neurology. So outside of that first 3 blocks, the start of my residency was actually pretty easy, I think. But now I'm starting to get back into the zone of residency. So I'm gonna have 3 weeks of wards, 3 weeks clinic, 3 weeks of wards, 3 weeks subspecialty, 3 weeks wards, 3 weeks ICU. So now I'm going to have wards happening more often. And I think I'm starting to get more into the flow of residency. So anyways, I'm just on the second day of my wards block now, Tuesday. And so I don't think I've been on this block enough to give like a thorough reflection of how things are going on wards right now. But I guess the reason I'm making this video is to focus. Well, I'll just say this. I got an eval back from a professor, from an attending that I worked with on my first block of wards way back in June, July. And I have a lot of respect for her and I like her. But anyways, out of 5, 1 through 5, the eval was pretty much all ones. And even for like professionalism, she gave me like 2 to 3 out of 5. And so I don't know. It just makes me wonder, like, because we get constant evals, from every professor we work with, and pretty much all of them have been on the lower side, like 2 out of 5, for me. Some 3s out of 5s. They say that I hesitate when I give presentations, that my differential diagnoses aren't good enough, things like that I need significant guidance, But anyways, for the most part, most of the evals I've gotten earlier, they haven't bothered me too much, because I was new and they did tell me, as I started residency, they said with these evals, you should expect to get, ones as you start, ones, twos. So I wasn't too worried about it. But this professor that I got the eval from, she hadn't submitted that eval, from back in June, July until today. And coincidentally, I've been working with her for 2 days, for the last 2 days as I've started on my new wards rotation. I've been working with her. And I can't help but think that she's maybe trying to say something to me by submitting that eval now. That I need to get my shit together. Because yesterday and today, I made a lot of mistakes, on words. So basically, before I get into the details of how I feel like, before I get into the details and reflection of how I think I can be a better resident, I'll just say this, which is that I have 2 choices. I can either be like, I can either say, this person is, I don't respect this person, I don't like this person, screw her, and I can say, whatever, I don't give a shit what she has to say. I can be like that. And with all due respect to her, maybe there is a chance that for some reason she doesn't like me and she gave me this evaluation. It's possible. But I think the more mature way to deal, to take this feedback, is to have an internal locus of control. Regardless of whether or not I deserve that feedback, And honestly, I probably did. I'm not saying I didn't, but regardless, even if I didn't, um, I need to have an internal locus of control. I need to focus on what I can change. I need to do what I can do to become a better resident and a better doctor, um, instead of, you know, complaining about it. So first and foremost, that's the mindset I have. Um, so I'm taking it seriously. I really need to put some thought into how I can improve myself. So what kind of stuff was on the eval? Clinical, decision making. So a patient will come in, or I'll pick up a patient from the residents who are covering the rotation before me. But for clinical decision making, a new patient will come in and I'll present the patient, and they're going to expect me to have a good differential diagnosis. So, for example, if a patient comes in with acute abdominal pain, what the professor wants to hear from me, the attending wants to hear from me as I present to them, is it can be biliary colic for this and this reason, but this is the reason why it isn't. It can be peptic ulcer disease, because this patient has abdominal pain, but the fact that he doesn't have a history of NSAID use, and most of the imaging was negative, says that it wasn't. But if we really wanted to know, we could do an endoscopy, so on and so forth. It can be, I don't know, hepatitis, but unlikely because of the labs, or the liver panel isn't that elevated, stuff like that. They want me to really have a good differential diagnosis of different diseases, and I feel like I'm doing that. Like I did that today with a new patient, but um, with the patients I picked up over the weekend, because they were coming from the residents before me, I didn't think too deeply about it. I just kind of copied and pasted their notes, and then kind of regurgitated what they had wrote in their notes to the attending during rounds. Like, I have one patient with gastric outlet obstruction. In other words, like gastric outlet obstruction means like the food can't get past, the outlet of the stomach. Um, and so I just, on rounds, instead of kind of giving my own words, my own take on why I think this is happening, I just kind of wrote what was in the note, like, the patient's history and things like that. I said, during the presentation, what was in the note, um, which is like, I is that a bad thing? I don't know, right? Because the resident before me did all this chart review on this patient, but I don't like. Does she? I'm picking up 4 patients. On Monday I picked up 4 patients. Does she expect me to do my own thorough chart review? Look through their histories and all that stuff, and come up with my own differential. And it's already being worked up, like, and we already had a plan. So I don't know. Um, but definitely in the future, what I'm going to make sure I do is, as those patients go away, the patients I picked up from the last panel, and I start getting my own patients, I'm going to make sure that when I'm presenting, I really have a differential for each thing. And the thing about internal medicine patients is that, unlike, say, surgery patients, like, for example, the case I just described would be a classic surgery patient, young guy, young male, abdominal pain, no past medical history. Classic surgical patient. You give that differential diagnosis. You decide what to do. Uh, but most patients are like 85 years old. They have like, they're already taking like 20 medications. Their labs are messed up. They'll have some like hypernatremia. High sodium, low sodium, high potassium, low potassium, whatever. They've got a bunch of other problems, and their reasons for admission and their complaints will be more wide. So for example, I'll give a differential diagnosis. On a classic internal medicine patient, they're going to have a very long problem list, like of different problems. Like one problem might be um, gastric outlet obstruction. Another problem might be, for whatever reason, they're not breathing that well right now. They require oxygen for some reason now. Why is that? So first of all, I need to give a good differential diagnosis for why they have, you know, gastric outlet obstruction and indigestion and abdominal pain. But they also want to hear, what's your differential diagnosis? What are the different possible causes of why this patient suddenly needs a nasal cannula to breathe? Um, and then they might also have hypernatremia or hyponatremia, and they might also have, you know, just other problems down that list. Chronic kidney disease, and we might be continuing their medications. Everybody has GERD. We'll continue their medications for GERD, and their PPI. And should we continue their hypertension medications? Why or why not? What should we do for DVT prophylaxis? A lot of patients, there's a score, a Padua score. You use that to decide whether or not they need anticoagulants. But anyways, they want a differential diagnosis for every single problem. And anyways, I haven't been the best at doing that, or when I'm presenting, I'm not the best at putting things into my own words, because what I do is I write my note, like a draft of my note, and I save it. I pull it up on my phone, and then I'm kind of looking through my phone and reading down the lines of the note. So anyways, I need to kind of say things in my own words. But it's hard because, like, am I just supposed to, through memory, say all of the different problems that the patient has? You know? And it'll take forever for me to handwrite, to transcribe. This is the problem. We're doing this, this, and this. And this is the problem. We're doing this, this, and this. I just don't get the point of, transcribing that onto a piece of paper when it's already written on the computer and I can just put it up on my phone. So anyways, I've been struggling with presentations. I mean, I felt like I wasn't, because I feel like I'm doing a good job of this objective assessment plan, but based on the feedback I've gotten, apparently I've been struggling. So I'm gonna try and like be more, how do I put it, descriptive when I'm giving presentations from now on. And I think that means I need to come in earlier. So, I today I woke up at 5 a.m. I got there at 5:30, and then I prepped the patients until 7. And then I went and saw the patients on my own, from 7 to 8, and then at 8 we rounded. But I think tomorrow I'm going to wake up at 4:50 and have a little bit more time to kind of actually think about the problems that the patients have. So yeah. And then the other thing is I always miss, I've been missing some stuff during presentations. That's the other thing. Like today, like discharge. With internal medicine, a huge thing is discharge, right? When is this patient leaving? What's your plan for when this patient is leaving? And what's stopping them from leaving? And it's just, it's a tricky thing because there's no easy way to learn it. It's just something that happens with time, with just thought. I feel like seeing how things flow in the hospital. Today I missed something, like a patient. There's a patient with a broken femur, and he's medically ready to go. He had his surgery, where we've got him off of all of his medications, all of his IV medications, intravenous medications. So medically speaking, he can discharge, right? Pending PTOT, physical therapy, what they have to say. So today when I was pre-rounding, before I rounded with attending, I looked through this guy's notes, but I didn't see the PTOT notes. And the reason I didn't see them is because on Cerner, the electronic medical record that we use, the default is that for notes, you only see the notes written by doctors. And so I forgot to change the viewing system to all notes. And anyways, so I didn't read their notes. And so on rounds, the attending was like, "What did PTOT say?" And I was like, "I didn't see their notes." And it's just little things like that, which I don't know. So that luckily the senior resident saw the notes and he said, "Okay, well, this is what it said." But that kind of stuff, I guess, makes me look dumb, right? And makes me look like I don't care. Um, and this attending was very nice. She was like, "Okay," you know, but she wasn't nice on the eval. So um, I just need to make sure I really look at everything. All of the notes. Because there's going to be a bunch of different for patients like that. They might be seen by orthopedics. They might be seen by PTOT. They're going to be seen by care coordinators. I need to make sure I read all of the notes, from the day, from, my last note to my next note. And I haven't been doing a good job of that in time in part because I haven't been good at time management and efficiency, and I need to work on that. Um, so yeah, I've been missing little stuff like that on rounds. Uh, what else? I'm just thinking about just today. I made some mistakes like um, yeah. So staying on the time management thing, like today, there was a patient who was set to discharge. She's set to discharge tomorrow morning, but we weren't entirely sure whether or not she's taking her home medications. There's a list of medications that she takes at home in the electronic medical record, but we weren't sure if she's actually taking those. So they wanted me to stop by her room in the afternoon, talk to her, go through all those medications, and make sure she's taking those medications. But I fell behind because a new patient came in at 1 p.m. and instead of being efficient, I ruminated on that patient, on their possible differential diagnosis and stuff, and look through up to date and through open evidence and through different research things to kind of figure out what this patient might have, because their chief complaint was kind of weird, and it also took a while for me to organize all their other medications and stuff in the note. So anyways, it took me forever to prep this guy's note. And I also had to, we had Buffalo Wild Wings for lunch, and my stomach didn't take too kindly to that. So spent a little bit too long on the toilet, I guess. But so I didn't get to it. I didn't get to getting a med rec on this patient, before afternoon rounds, before running the list. And anyways, so and so I told my senior resident, I was like, I was gonna do this, but I didn't, and I know we're gonna run the list at 4. And he was like, "That's cool, man. Just do it tomorrow morning." But when we run the list, I was like, I told the attending, I'll get to this tomorrow morning. And again, she looked at me like, "Okay, that's fine." But I'm guessing in her head she was kind of pissed off. That might be something which inspired her to do this eval. So time management is important. So I just need to be more locked in, and make sure I'm more efficient with my time. And then the other stupid thing I keep doing, and I fully admit my fault on this, is well, I don't know. It's just, so the way rounds work, and by the way, the reason I'm lying on my bed here is because I'm going to go to sleep as soon as I'm done filming this, because it's 8 p.m. and I want to wake up at 4:50 a.m. tomorrow, and I'm already sleep deprived. But the way rounds work is, we'll go to the patient's room and I'll present the patient in front of the patient's room to the attending physician, and then after we're done, we talk. I talk to the senior resident, I talk to the attending, we make a plan. We walk into the patient's room, and I'm the one who's supposed to say the plan to the patient. But there's been multiple occasions where I've been to, I forgot to say certain things that we talked about in the hallway to the patient. And usually, I write down on my piece of paper, everything we talked about. So I'm good about saying it to the patient. But a lot of patients' rooms in my hospital here, they have contact precautions. So for a lot of patients, you have to put on, a gown and a face, a mask and gloves. And I'll put the sheet of paper into my back pocket on my scrubs, and I won't be looking at it while talking to the patient, so I'll forget a few things. So anyways, like today, I talked to the patient. I told her, this and this and this is the plan, and then the attending was, and we also talked about this other thing, and then she looked at me, and I was like, oh yeah, and let me just think about what that was for a second. What was that? Sleep deprivation, man. My short-term memory is also just crap because of sleep deprivation. But what was it? I don't remember. I don't remember. Oh man. Anyways, she looked at me and she said, "We also talked about this other thing." So, oh, oh yeah, it was the heart rate. So one patient's heart rate was really low, and so I said, "Okay, so we're gonna stop your beta blockers," is what I told him. And then the attending kind of gave me a disappointed look and said, "We're also going to think about potentially starting you on a blood pressure medication if your blood pressure stays up," because we had also mentioned that in the hallway. So I forgot to say that to the patient, so the attending had to take over for me and say that. So I need to get better at regurgitating my plan to the patient, and that means just kind of being a better listener and making sure I have it all kind of recited in my head before I step into the room of the patient. And it also means sleeping, right? It means sleeping, so I have a good short-term memory. I mean, it's incredible, um, what just a few days of sleep deprivation does to you. Because, like, somebody asked me, like 3 p.m. I was talking to another resident on another team, and he told me, who's your attending physician, and I was like, I didn't know. Like, it took me a while to say, oh, it's her, because I don't know. My it's just, I don't know. Tired. So yeah, I just need to be better at these things. Um, Something else, and I'm gonna make a much longer rant about this later, but step three. When I come home, I do UWorld for step three, and I just studying step three is such a scam. It's just such a waste of time, and I'm a worse doctor because of step three. Because instead of instead of actually treating my patients, instead of focusing on my patients, instead of always thinking about my patients, instead of studying up on my patients, when I come home, I'm doing freaking UWorld for step three. I'm studying stupid garbage, which is not going to have any, you know, relevance to my clinical duties, um, after I take this stupid test. And during like noon hour, even, I'm trying to get through my Anki deck. I'm making an Anki deck for step three, and I'm trying to get through that. Step three has been disruptive as well, okay, because it's just another one that things on top of things. Um, and I'll rant about it later. There's a whole lot I want to say about it. So I won't get too deep into that. Um, but the very last thing I'm going to say before I go to sleep is this. There's a lot I don't like about medicine. There's a lot I don't like about academia. Uh, a lot. But at the end of the day, 3 years from now, regardless of whether or not I choose to do fellowship, 3 years from now, when I'm done with internal medicine residency, I need to be ready to be an independent attending physician. The buck, the end of the line. The one who makes the decisions. And if I'm gonna be lazy, or I don't know, blow off feedback, or not work hard, um, then I'm going to be a subpar physician, and that's going to be bad for patients, and it's going to be bad for me. You know, I don't want to be that doctor that, you know, is always second guessing themselves and continues to feel stupid every single day. Like, you know, I feel stupid every single day right now because there's so much to learn, but I don't want to be the attending who feels that way. So, um, and there's no excuse for me. I mean, you know, at this point, you know, I live alone. Right, I'm not tied down to anything. You know, I'm single. There's you know no distractions in my life whatsoever. So there's no reason why I can't 110% focus on my job, and that's what I need to do. I need to make sure that I can be the best doctor possible within these next 3 weeks. So you know, within these next 3 weeks of this, you know, hardcore word block, but also within all of residency. But really, really within these next 3 weeks, I want to focus as much as possible. And this attending physician who gave me this bad eval, I'll probably only work with her for another 4 days before it gets switched to the next hospitalist, the next attending physician. So I'm probably not, no matter what I do, I don't think I'll have a good enough impression on her to make her change her impression of me. But it doesn't matter. What I need to do is always just focus on being the best version of myself possible. And then, God willing, inshallah, I'll find that reward, you know, slowly but surely. As with anything in life, I'll find that I'm getting better. So, you know, that's it. You know, that's how I choose to take this feedback. And I did do a little bit of a reflection on how I can become a better doctor. And yeah. And I'll just show this one last thing before I go to sleep. This guy, Khabib Nurmagomedov. He's a UFC fighter. My favorite UFC fighter. That guy, undefeated. And he's a rich guy. He doesn't need to work as hard as he does, but he does. He works hard. He's a very religious guy. You know, he sticks to his all the, you know, demands of his faith, and because of that, he's undefeated and he's successful, and people look up to him. And you know, that's what I need to be: successful and somebody that people can look up to. So, anyways, let's keep grinding. I'm gonna wake up at 4:50 a.m. tomorrow. I'm gonna go to sleep right now. No distractions, and I'm gonna do better day by day. So you guys have a good one too, and good luck to anybody who, for whatever reason, watches my videos. And yeah, all right, good night.